Hello, everyone, and welcome to our Monday Night IBD video series focusing on unmet needs in IBD and new approaches to IBD care. This series is supported by educational grants from AbbVie, Janssen, and Takeda. And before we start, please take a moment to answer the pre-polls linked below or by using the QR code shown on your screen. Let us know who you are. And remember, this is a CME certified program, so the tweets below also include details how you can obtain your credits. I'm Dr. Aline Charabaty, founder of Monday Night IBD. I'm an associate professor of medicine at Johns Hopkins School of Medicine. I'm the clinical director of the IBD Center at Johns Hopkins Sibley Memorial Hospital in DC. And I have the privilege today to be joined by my colleague, Dr. Bincy Abraham. She is a professor of clinical medicine at Houston Methodist Academic Institute. She's also the director of the GI Fellowship Program and the co-director of the IBD Advanced Fellowship Program at Houston Methodist. Bincy, welcome.
Thank you, Aline, for having me.
We'll start with the sub-Q therapies that are now available to us that we have been using for many years in IV form, IV vedolizumab and IV infliximab. Tell us why we have the sub-Q form. What is the advantage of switching our patients from the IV to the sub-Q form, and who are the right candidate for that switch? And of course, I would love it if you can share your experience with your patients regarding this topic.
Absolutely. Of course, it's always nice to have additional options for our patients. And of course, we know infliximab was the first biologic to ever come out, and it really changed the lives of so many patients. However, it's always been IV form, and it's not as convenient for patients who need to actually go and drive to an infusion center and get that done, where they have to wait 2 hours for the infusion to be completed. Not to mention, getting the IV done and post treatment as well. So convenience is really a game changer for having infliximab, a really well-known biologic that was used over the decades in a sub-Q form. And of course, vedolizumab, it is a anti-integrin agent. We've known its use both in UC and Crohn's, but I think in general we've used it as an earlier agent in ulcerative colitis and in both diseases in itself. But again, it's an IV infusion, granted only 30-minute infusion time, but to have the convenience of every 2-week dosing, I think it's really been hugely beneficial for our patients, especially that need to take additional time to go to infusion center, get an IV in, and so on and so forth, unless, of course, getting home infusions and insurance is actually covering that. So first and foremost, I would say convenience has been the biggest benefit for having those two options for our patients.
I agree. And I think for many patients who don't have access to an infusion center, we often talk about social determinant of health being barriers to accessing care, not being able to drive, not have a car, not have transportation, or have to miss working hours. But I'm really fascinated by this kind of paradigm shift. The data that we have show that now with the sub-Q formulation, we might have better or more stable drug levels, especially with infliximab. So tell us more about this. What's going on, and how do you apply that when you discuss it with patients, when you're discussing that switch?
Right. I completely agree with you. We've kind of grown up with this fact that IV potentially is stronger, faster. In general, we start with IV induction dose of any of our medications, even the ones that we end up, switching to sub-Q, a standard FDA approval. The IV dose is typically higher, right? So we kind of have that ingrained in ourselves. But the nice thing is, in both the registrational trials for vedolizumab and for infliximab sub-Q, DYYB, they actually showed that the efficacy is the same, right? We had to show the similar efficacy in order to get FDA approval for it. But not only that, we looked at trough levels. Because we're getting the drugs every 2 weeks, we're actually getting very more stable drug levels and perhaps even higher levels than the IV that we're giving every 8 weeks. So that's an additional benefit to the sub-Q availability, that yes, it's sub-Q, but doesn't mean it's not as strong or efficacious. In fact, it's similar, at least in similar in efficacy, but potentially even better. So it's actually a good thing to have that as an option, especially if you have patients who, let's say, are on, let's say, every 8-week dosing or every 6-week dosing, and then it's just like a few days prior or a week prior, they're having a bit more symptoms, but not huge enough to say, oh, we need to move you out to, back in closer to like every 4-week dosing or so. So this could be another option for those patients who just have a little bit more symptoms. They can't wait out the full 6 or 8 weeks before they get their next dose in. Getting more drug, even though it's a little bit less at a time, can get them to more stable dosing and also perhaps more efficacious for them. And especially in those patients who can't wait that long, they actually are having either some residual GI symptoms, or in a lot of my cases where their IBD is in remission, but their joint pains or other extraintestinal manifestations are starting to bother them before they get their next dose in as an IV. And then they feel better, but then have to worry about them flaring again, even though it's necessarily not their gut. Sometimes their EIMs, they're bothering them right before their next dose is due as well. So I think it's a huge benefit for those patients.
Yeah, I think this is very interesting because it's true that sometimes the inflammatory bowel disease is under control, but we're having those joint pains and maybe getting a more stable trough level and maybe a higher trough level can really help these patients instead of having to add another medication to address the joint disease. So, Bincy, in your practice, who is the ideal patient who you would offer that option to?
Yeah, so a great question. So let's say we have a lot of patients already on the IV dosing of Vito and IV dosing of infliximab, and it's like, well, they're stable on it. Why make the switch, right? So for sure, the patients that are really complaining all the time of, having to get out of work to get to the infusion center, or it's a long drive or whatnot, these are the ones that we really should proactively approach and say, hey, we have another option for you. That way it will take away the inconvenience of the drive here or the parking fees or whatever it may be that's, really bothering them, not from a medical standpoint, but from the patient's, standpoint. So those would be the ones to, approach early on. Now, Vito and infliximab DYYB, actually, both of them are approved for UC and Crohn's now. So vedolizumab got both of the approvals. So the patients who, complain about the inconvenience, the patients I mentioned that, have some more symptoms closer to their IV dose, they can't wait that long, be it GI symptoms or extraintestinal manifestations are the ones that I would actually recommend or encourage them to, move forward with the sub-Q dosing as well. Now, let's start with vedolizumab, for example. Now, it's a little bit different in the sense that, well, if you have a patient who's you're thinking about starting them on vedolizumab, and they want to be on the sub-Q, well, we still have to start them on IV induction, and you need minimum 2 IV induction doses. So you start with standard week 0, week 2, the 200 milligram IV induction dose, and then at week 6, instead of giving them the third IV induction dose, that's when you start them on the sub-Q, the 108 milligram dosing, and then from that week 6 onward, they'll get every 2-week injections. So that's how you would do a new start. How about a patient who's like on maintenance, Vito, every 8-week dosing, so they're already on that? Then what you would do is after, let's say they get their week 8 infusion, and then they're supposed to get their next dose 8 weeks later. Instead of that 8-week IV, they're going to start their sub-Q at that 8-week margin. And then from that day onward, they're going to get every 2-week dosing. It's not week 8 and then week 10 all of a sudden. It's week 8, 8 weeks from their last IV dose, and then they start. So whenever they're supposed to get their next IV is when you start their sub-Q and go every 2 weeks thereafter. Now with infliximab, at least here in the US, FDA approval, for new starts, we have to do 3 IV induction doses, and then they can start as early as week 10, so 4 weeks after their third IV induction dose. And then they do their 120 milligram sub-Q every 2 weeks thereafter. So that's how you do a new start. Now, how about someone who's already on infliximab, let's say standard every 8-week dosing? Again, what you would do, similar to the vedolizumab, would be at that next IV infusion, instead of giving the IV infusion, do the sub-Q and then moving forward every 2 weeks thereafter. So there's some subtle differences between the two medications, but that's kind of how you would time it when you're either starting a new patient on either of the two drugs versus moving them from maintenance onward.
That was absolutely very helpful. Is there a type of patient or rather a type of disease or disease behavior where you would make the switch, or maybe we don't have data on using sub-Q formulation? I'm thinking about, perianal Crohn's on infliximab. I'm thinking about maybe a patient with pyoderma gangrenosum and anti-TNF are often, very helpful for that. And we always worry about PG coming back because it's so difficult to treat. Do we have any data on these particular situation? And are these patients where you would consider this switch?
Yeah, so I personally don't have any concerns about switching any of these patients, actually. For example, the perianal disease patients, we always talk about, especially with infliximab, that higher levels are typically needed to treat, fistulizing disease. So in the case with sub-Q, we're actually able to get even better levels, getting every 2-week dosing. Why not make the switch? In fact, it may potentially even be better than being on the IV dose, right? So in fact, there was a European study actually that looked at perianal Crohn's patients on the sub-Q infliximab, and they actually they looked at two groups of patients, actually. One group who were in remission to make sure no one fell out of remission, and comparing the two groups versus those who had active perianal disease to see actually who healed up. There was really no major difference. The sub-Q actually did help in both cases in preventing a flare or worsening of the perianal disease, and in actually healing and closing up the fistula as well. So we have some real world data, mainly in Europe, because it's that sub-Q version of infliximab has been out for longer there. So that's also reassuring that even though we may not have big randomized controlled trials on perianal fistulizing disease, which is so hard to come by, that even real world evidence shows benefit. And the way that we're seeing levels and trough, being higher with sub-Q, I have no qualms about, switching those patients. Now, regarding the pyoderma patient, again, infliximab, it's still the same medication. If infliximab IV helps them, infliximab sub-Q form should help them too. And again, going back to, if we're looking at trough levels, we're going to get more steady state of the drug. So I really can't see anyone that I would not switch from the medical standpoint, withholding, of course, like the convenience or patients having issues with injections or insurance and things like that. Yeah.
That's wonderful. Thank you so much. We're going to shift gear and talk about, combining effective therapy, whether to biologic or biologic and small molecule. You and I were at the same conference, and you were sharing with me the extensive experience you've had combining therapies. So my first question to you is, why do we do it? And who are the good candidates for combination therapy? And who are the potential people that you start combination therapy on?
Yeah, very great question. I think combination therapy is like the wave of the future for treating IBD. And to tell you the type of patients I've started, I can tell you one of my earliest group of patients, this was like actually over a decade ago when we started doing this. I had patients who had multiple surgeries, including total colectomies, permanent ileostomies, but with still severe small bowel disease activity, where they were at risk of short gut syndrome if they went through additional surgery. They were on TPN, parenteral nutrition, weighing barely 70 pounds and low albumin, and they had failed multiple agents. So I had to choose the latest available agents, and one of them wasn't working, so I had to add on the other agent as well. And when I saw how efficacious this was for one of my first patients who had started, I was blown away at how well they did and the fact that I didn't see any safety signals. Of course, I started with the what I like to call them like my gateway drug for combination therapy, which was initially at the time vedolizumab because it was gut selective. It wasn't really immunosuppressive. So I felt safe adding an anti-TNF or an anti-IL-12/23 to the agent and seeing how these patients did. And when I saw the combined part of it showing efficacy and really no increased safety issues, I was like, oh my gosh, I have something here. I got to take care of more of these patients. And then moving forward, perhaps a decade or more, where we now have anti-cytokine agents that are similar in safety, such as the anti-IL-23s and anti-IL-12/23s, I felt comfortable using that as my gateway drug and adding on other anti-cytokine agents such as anti-TNFs or JAK inhibitors. And I've seen amazing results for my severe disease phenotype patients. And so I've been really happy with this combination I've been able to for this group of patients. Now, when you asked me earlier, who would I choose the combination therapy for? Again, it's not every single patient that walks into my office. I have someone with moderate disease, or I have someone who's elderly with multiple comorbidities and risk factors for other things. I'm going to be very careful in how I select therapy. Typically, these patients I've used combination therapy have been younger patients, really no other major comorbidities. It's a disease phenotype, their severity that's really getting at them. So I need to attack their inflammation through multiple pathways. And that's really who I've kind of, chosen. Another group of patients are actually patients who are doing well, let's say, for their inflammatory bowel disease component, and they have either an extraintestinal manifestation that's not being fully covered, and I'm afraid to switch them completely to a different mechanism of action, where I'm adding on a different agent that, let's say I'm on a gut selective agent, I need to add on something as an anti-cytokine to help with their extraintestinal manifestation. I've done that, where I may be able to get away with lower medications, in that route, or if they have an additional comorbidity, such as, ankylosing spondylitis or psoriatic arthritis, where if, let's say, in general, I try to use a medication that will cover both the IBD and the other comorbidity, if at all possible. But in some cases, one mechanism may not help one comorbidity and the other didn't help with the opposite. So where we have to be very cautious about, okay, how do we choose an appropriate therapy that's going to take care of both disease? And if it doesn't work, how can we choose two agents that may work in taking care of both diseases? So that's kind of my initial foray into starting combination therapy. But really, it's really personalized to that patient with more severe disease or multiple diseases, in a sense, where I needed to use different agents to get them under control.
Absolutely. So I think you and I practice very similarly. And so what I hear you is like the two main reason for using combination therapy, either severe disease, a disease refractory to 1, 2, 3 therapy maybe, and then combining 2 therapies to achieve our goals for clinical remission, avoiding more surgery, avoiding short gut, avoiding debilitating symptoms, terrible perianal disease maybe. And the way you choose from the menu is anti-TNF or JAK inhibitor, and then your gateway drugs, the Vedo, IL-12, IL-23. I've seen some report of anti-TNF plus JAK. I haven't been brave enough to do that combination. But I think it's probably we're more comfortable choosing maybe a highly effective with potential side effect drug with a very effective and a better safety profile drug. And then again, patients with inflammatory bowel disease who can develop extraintestinal manifestation throughout their journey, right? So as you said, we usually use a therapy that helps both the IBD and the EIM, but EIM can develop, later in the course of the disease. And sometimes we do need combination therapy with 2 different drugs. So this is mainly like our real life, right? So we're, how we do it. But I think, ideally, and I wonder if you agree with me, and I can see now that there's some clinical trial maybe trying to address that. So most of the data we have on combination therapy is case series, real world data. But ideally, I think it would be nice also to be able to identify who are the patients who at the time of diagnosis have poor prognostic factors and might need this combination therapy from the get-go to get them in remission and then maybe remove one of the therapies. We always talk about how the first biologic or the first drug that you choose in IBD is really where we're going to have the most effect in terms of inducing clinical remission. And maybe some patients early in the course of their disease just need 2 drugs because their disease is either very extensive or severe, or they have other maybe genetic factor component that's going to make that disease more refractory to therapy. So I've seen several clinical trials looking at that, looking at starting combination therapy in new diagnosis of UC. We've seen the Vega trial, guselkumab, which is an IL-23, with golimumab, which is an anti-TNF. There are more follow-up trials on the way, like the Duet UC and Duet Crohn's disease. What kind of answers you want to get from these trials? I think in these trials, probably, the trials are looking at all comers, new diagnosis, moderate to severe UC. But what kind of answers would you like to get from these trials to help us adapt this in real life? Like you said, not every patient needs to be started on combination therapy, but some might need it early on, and it would be great to be able to identify these patients.
Right. I'm super excited that we actually have randomized clinical trials, large-scale studies looking at this. And our earlier phase 2 type data is actually showing, benefit, and very similar to what we're seeing in the real world experience as well. But what I would really love to see in these combination trials is trying to get higher efficacy. If you look at even the latest types of, FDA-approved medication, we're slowly inching towards 70% efficacy in, some of these factors like endoscopic remission, clinical remission, et cetera. But wouldn't it be nice? I mean, withholding, ideally would like to get a cure and, prevent the disease, but to get to over 90% for our patients to get into remission, and not just symptomatic remission, but true deep remission, endoscopic remission, maybe transmural healing, et cetera. That's what ideally I would love to see. I know we haven't been able to get there with our monotherapy agents, but perhaps with, dual therapy and seeing this in a randomized setting and seeing the differences between one agent versus the other versus the combined I think would be phenomenal to see that. So I'm super excited to get higher efficacy rates first and foremost. And secondly, safety, to confirm that the safety is there. I think in our own experience, the safety hasn't been an issue, especially when we selectively choose who needs to get on combination therapy. And so if we see this similar safety, then maybe we need to be considering combination therapy in the majority of our patients. Now, keeping in mind dual advanced therapies can be quite expensive. So you did bring up this great point about de-escalation. You touched upon that briefly. And I think the next step would be, if we had these patients on combination therapy, what would be some factors and who would benefit from de-escalating? So actually stay tuned, Aline. We're working on some of our data we have a lot of patients on combination therapy. We've been successfully able to de-escalate a lot of them. And now what we're looking into are what are the factors of successful de-escalation versus those that weren't so successful. And of course, in my clinical aspect of these patients, I hate to de-escalate anyone who's not obviously in endoscopic remission, or easy enough to say not in symptomatic remission. We're not going to take off meds, right, in that sense. But if we're able to get them into deep remission, then perhaps there are factors that will tell us and provide guidelines for providers to say, okay, you're on combination of this. Okay, let's start de-escalating you because it'll be safe because you met all these criteria. And then how do you choose which therapy you need to de-escalate, right? It's another question. So it all depends on multiple things, the patient factors, what did they respond to the best? And for the biologics where we can actually check drug levels, who has adequate levels or high levels or just low levels, and then make the decisions accordingly as well. And also when I typically ask the patients too, without having any specific CRP or calprotectin or lab or endoscopic data, it's which medicine do you did you really feel that really helped you? And oftentimes the patients make that decision for me. So there are, multiple factors in that, but I'm hoping to get all of our data together for publication to help guide the escalation of these combination therapy patients as well. So that would be neat to see. And the other part I'm super excited about is that currently in the real world, we have to give, for a combination therapy, one patient gets the IV of one drug and a sub-Q of the other, or an oral agent or a sub-Q, et cetera. But I'm excited to have one injection, let's say, with two drugs in it, one shot. Like, that would be great. So reduce the injection burden. Or in the future, perhaps have two agents, oral tablets, but once a day combined into one therapy. Wouldn't that be nice? Reduce pill burden for a patient. So those are things I'm actually most excited about from trials and combination therapy data coming out from there.
Well, that was a wonderful conversation. You got me excited about the future. I feel like we're having more answers, but also more questions, right? And then I think the whole process, sometimes it's a real world experience that informs the clinical trial as opposed to the other way around. And I think combination therapy is one of those instances, which is really interesting to see. But it's true that a lot of good opportunity or better opportunity, hopefully, to serve our patients, especially patients with more severe disease, refractory disease, and really allow them to have the quality of life that they aim for and get them healthy. So this was a fabulous conversation. Bincy, thank you so much for joining me today. Like I said, I always learn something from you. I appreciate the time and the energy you give us today, sharing your experience and expertise and knowledge. And before you all go, please be sure to answer the post-polling questions under the video. And don't forget to claim your CME credit using the links below the video. Thank you, everyone, for joining. Dr. Abraham, thank you for being here.